Thank you, Mr. Pattakos, for your excellent speech. I will ask Dr. Sardari for a comment maybe on that. How often are you feel able to go through endoscopic, or you prefer for these cases external approach?
So I think in 98% of the cases, we do endoscopic operations, and the choice of endoscopics is based on the anatomy, whether you can do safe peripheral cannulation, whether you can enter the chest safely. So that is the main consideration if you choose the approach. With regard to the pathology, that is not that is not the issue. So we can address all the pathologies. I think in the tricuspid regurgitation, what is important, we are very aggressive in the sense that if you have a patient with mitral valve problem, if you have the annulus more than 40, we do a concomitant tricuspid, because otherwise this patient have a greater chance to come back. And we try to do that part of the operation on beating heart. There's no established evidence that is better, but what we see, or what I experience in clinical practice, if you have a patient on beating heart, and once you're stitched a bit too deep, or you see directly that it affects the rhythm, so you can correct that, which you cannot correct that if you have already arrested the heart. And the other thing is, obviously, the main issue in the tricuspid disease is that these patients are referred too late. Too late because they have already a dilated right ventricle, poor right ventricle, or moderate right ventricle. So I think if in that regard, we think if you do that part of the operation on the beating heart is much better, especially if you have an isolated tricuspid regurgitation. In the selection of the patients, whether open or endoscopically, the critical questions that you have to ask: what is the pathology? If there is a tenting of the tricuspid leaflets, just an annuloplasty ring would not be sufficient. The other thing is a function of the right ventricle and the right pressures, whether there is a pulmonary hypertension. So in all those patients, actually you need to do a right cath, and you need to do a reversibility test, because even if they have a pulmonary hypertension, but it's reversible, still you can operate those. So it is very important to have a good procedural planning in these patients.
Thank you. Dr. Perreas, are you of the same opinion? Are you asking systematically right catheterization before ill patients from the tricuspid valve?
If there is pulmonary hypertension, yes, we need to be more accurate in defining details of the level of dysfunction. And as I said, there is a scoring system. We need to check their albumin, their liver function, but that does not apply to all the cases. I'm sure Dr. Sardari agrees. So the common patient that we do endoscopically, we did see the previous decade that they had an NT-proBNP of about 1,000, and we published that, which shows again the reality of the real world. So they are patients with primary mitral regurgitation, and yet they appeared late. So about 20% of those cases that we did endoscopically also had at least moderate tricuspid regurgitation. So in all these cases, if the RV is functioning well and there is no extreme pulmonary hypertension, so anything above 60 or 70 will create a concern, not to the way of the approach really, but to the real expected result. So yes, reversibility of the pulmonary pressure is extremely important to us too, but only on a selected group of patients.
Thank you.
Correct myself, because we do the right cath in patients coming for mitral or concomitant if the pulmonary pressures are more than 55. So, but in isolated cases, we do in all patients because it's a different kind of pathology.
Important remark. Thank you. Dr. Pattakos, in your everyday experience, you said before that one study doesn't make the difference between one or two valves, mitral and tricuspid repair, on the need of pacemaker after surgery. Is this true also in real life, or is just in studies?
No, what I had shown was that when you add the tricuspid, you go to a 15% pacemaker rate.
Yes.
Whereas if you have the mitral, it's about 3%. Let's say or something
Personally,
like that.
I think I have more than 15%.
Yeah. So it's something that and I appreciate your honesty. When we have these cases, a lot of them end up getting it, whether it's 10% or 20%, whatever the number may be. There's obviously a lot of these patients also have pre-existing conduction disturbances, which it's not really the surgeon's fault if someone was due for a pacemaker anyway, and then they come to the hospital and it's the first time they actually have an evaluation, and it's the first time that their arrhythmias are noted. I think the other thing that's important to note here is that what I hate, and this happened to me a couple of years ago, and since then I've changed my practice, is you do a mitral and tricuspid repair, transesophageal echo in the operating room, everything is perfect. You come out, it looks like the patient's going to need a pacemaker. They get a pacemaker, and guess what? The pacemaker lead causes tricuspid regurgitation. And now the patient is angry at you because in private centers, they pay more for the tricuspid ring. Now they're going to pay more for the pacemaker. They still have a tricuspid problem. So what I've asked our arrhythmia physicians, cardiologists to perform is, once they place the pacemaker wire, please perform an echo in the same setting. So if you have a problem, you can adjust the wire. They don't like to do it because they feel that it interferes with the sterility of the procedure that they just did. And granted, infection of a pacemaker is a horrendous thing to have happen. But I asked them to cover this area quickly and then perform an echo focused on the tricuspid valve to ensure that they didn't cause TR. But I think that this is an issue that we're becoming increasingly aware of.
Maybe with intraventricular pacemakers, this issue will be solved.
Yeah, lead this. Yeah.
I have also another question for Dr. Kamentsidis. How easy was to implement your the endoscopic program in your center? Because I think you have changed from one to the other. In the new center, you are now. Your was in. Are you Lucas?
I was always in the same center, and we had the luck to be assisted by a proctor for the first 85 cases. So until create confidence, it took us some time. 85 cases, it was about 2 years to be autonomous. But we had the luck to have all the support and from the side of the clinics concerning infrastructure, instruments, everything.
Thank you. Other questions? I will invite the next two speakers.